Good morning, good afternoon, and good evening to colleagues and friends, and thank you very much for joining us today for the ICAP Grand Rounds. I'm Wafa El Sabr, the Global Director for ICAP, and it gives me great pleasure to introduce our speaker for today, Professor Dr. Jean-Michel Molina. So I'll tell you a bit about Dr. Molina's background and expertise. So Jean-Michel Molina is a professor of medicine at the University of Paris Cité, and he's also the head of Infectious Diseases Department at the Saint-Louis and Lariboisière Hospitals in Paris. He's been involved in several studies assessing new drugs and strategies for the treatment of HIV and has chaired the AMR's clinical trials group for the past more than a decade. And his department follows a cohort of more than 6,000 people living with HIV. He's also a member of an interim research team that's investigating cell biology of viral infections at the Saint-Louis Research Institute. Since 2018, and most relevant to our conversation today, he has been involved in research that's focused on the prevention of HIV and other sexually transmitted infections. And he's led the ANRS's Ibergay PrEP trial in men who have sex with men, with his unit following more than 4,000 people on PrEP. Most recently, Jean-Michel has taken a new position as medical director of Pasteur Institute in Paris, with the task of fostering translational and clinical research in infectious diseases. It gives me great pleasure to introduce Dr. Molina. He is going to speak for about 40 minutes or so, which will be followed by a conversation, your questions, answering your questions and your queries, which will be moderated by Jessica Justman here at ICAP. So welcome, Jean-Michel.
Thank you, Wafa, for this very kind introduction. Good morning, good evening, good afternoon, everyone. It's a real pleasure to be here today with you. And I'm going to share my presentation, and I've been asked to talk about the doxycycline post-exposure prophylaxis, so I hope you can see my slides well enough. And I'm going to talk also on the impact of these new, still controversial prophylaxis and the impact on antimicrobial resistance, which is obviously an issue when you use antibiotics. As you know, there is globally an increase in the incidence of bacterial STIs, and according to WHO, there is more than 1 million of curable STI diagnosed each year, and you can see on the map the region in the world mostly affected by these STIs. And if you look at the US itself, the data from 2024, although there seem to be some small decrease in chlamydia and gonorrhea incidence, there is a concerning increase in syphilis, and especially in newborns. And indeed, this is something that is seen also in other countries. So we know that these STI are raising a number of issues. For gonorrhea, we know the issue of increasing incidence of antimicrobial resistance. Syphilis, I just talked about the issue in pregnant women and the increased rate of congenital syphilis. And for chlamydia, we have this increase in LGV in MSM. If we look at people using PrEP, and this is a study conducted in Australia where they look at the incidence of STI among PrEP users, and you could see that with a follow-up of 1 year, you have a very high number of STI diagnosed. But what's interesting, and I'd like you pay your attention to the fact that only 25% of those people using PrEP accounted for the 2/3 of all STIs. So that's important to keep in mind when we have to design prophylactic strategies in people exposed to STIs. So what are the tools we have today to contain the STI epidemic and to prevent STI acquisition? So we have the classics: abstain, be faithful, and condoms. And indeed, condoms should be still used as a way to prevent STIs. The test and treat strategies, which is used for HIV, is also advocated for STI, although we don't have real data to suggest this will have an impact on the STI epidemic. PAC notification and treatment is also historically a good practice. Again, difficult to assess its global impact on STI incidence. We do have a very effective vaccine for viral STIs, which are available for hepatitis A, hepatitis B, for papillomaviruses, for Mpox. Unfortunately, so far for bacterial STIs, we don't have any good vaccines, and that's indeed an issue, and research on this matter is still ongoing. And that's why we are left with antibiotic prophylaxis for STI at the moment. And we started to assess STI prophylaxis in people on PrEP in the wake of the IPEG PrEP trial, when people were so happy to be protected by PrEP, so that they were now concerned about the high rate of STIs. And we said that we had to do something about that and test new strategies to prevent STI. And we decided to use doxycycline, a generic antibiotic, to see whether in an open label randomized trial we could assess doxycycline post-exposure prophylaxis, or DoxyPEP, with single dose of 200 milligram given within 24 hours up to 72 hours after sex, or no PEP. And what the reason why we use doxycycline was that at this moment we don't have any resistance documented for doxycycline, either for chlamydia trachomatis or for treponema pallidum. And also DoxyPEP has been used successfully to prevent other infectious diseases, and its use is limited in France for acne or malaria prophylaxis, not really for the treatment of bacterial infection, but that could be different in other countries. Also in France, we have already a high rate of tetracycline resistance Neisseria gonorrhea. The impact of increasing the use of doxy for gonorrhea would not be such an issue. And anyway, doxycycline is not used for the treatment of gonorrhea because of this high rate of resistance. On this slide, I wanted to remind you the mechanism of action of tetracycline. And tetracycline are bacteriostatic antibiotics, which binds to the small ribosomal subunit in the bacteria, and therefore blocks protein synthesis. And there are different ways the bacteria can become resistant to tetracycline. Some of the mechanisms are chromosomal mediated, and other are plasmid mediated. And I wanted to bring your attention to this TETAM mechanism. This is a gene that is on a plasmid, and this gene can synthesize a protein that can actually block the binding of the tetracycline on the small ribosomal subunit, therefore blocking the activity of this antibiotic. And this is a gene that is associated with high-level resistance of tetracycline. In the IPEG trial, what we've seen was actually a strong reduction of chlamydia incidence in people using Doxy PEP in blue as compared to those without PEP in red, with a relative reduction of incidence of nearly 70%. And the same relative reduction was seen for syphilis. So these data were published in 2018, so some time ago now. But this study was not that large. The follow-up was only 9 months, and so we wanted to have confirmation of these data. The first confirmation came from this study conducted by our colleague from San Francisco and Seattle, the team led by Annie Lutke-Meyer, which published the data in the New England Journal of Medicine 2 years ago, where they study MSM and transgender women living with HIV or using PrEP, and they randomized this population 2-to-1 to either Doxy PEP or no PEP, using the same Doxy PEP regimen we used in the IPEG study. And they confirm actually the strong reduction of STI incidence by 65%. And the reduction was actually dramatic for chlamydia and syphilis, nearly 80%. But they also saw a decline in gonorrhea incidence by 50%. In addition, in the ERS DoxyVac study with a similar design, in a similar population of people on PrEP, MSM, and transgender women, we also confirm the strong activity of DoxyPEP in terms of reduction of the incidence of chlamydia and syphilis by nearly 80%. So overall, all these data are quite consistent in this population on the strong impact of DoxyPEP on chlamydia and syphilis incidence. When you look at adherence to DoxyPEP, which is important because, as you know, any prevention strategy only works if it's taken. And because it is on demand, it was important to look at what people actually did. And we measure doxycycline in plasma and urine, and we could show that 60 to 70% of the participants in the DoxyPEP arm use indeed DoxyPEP. Usually within 15 hours post-sex, with a median of 3 doses per month, so less than 1 dose of 200 milligrams per week. And what was interesting, and we presented that data at the recent European conference, is when you look at the incidence in those who have doxy detectable at every visit versus those without doxy detectable, you see also an increase in the efficacy of DoxyPEP on the incidence of these STIs. So clearly there is a dose relation efficacy in terms of preventing these STIs. What about resistance? For chlamydia, as I said, there is no tetracycline resistance so far in humans in chlamydia trachomatis. However, it's important to know that in pigs, chlamydia suis has acquired an efflux pump, and nearly 90% of these chlamydia suis strains today are resistant to tetracycline because of the large use of this antibiotic in pigs, actually for increasing their body weight. And although it has not been shown in vivo, in vitro, it is possible to transfer this gene from chlamydia suis to chlamydia trachomatis. So far, studies in humans, in the trials, and also when you do, tissue culture and you try to select for chlamydia resistance using subinhibitory concentration of tetracycline, and you do multiple passages, we were not able to select for resistance mutation. But this is something we need to keep in mind. For syphilis, that's the same. Treponema pallidum has no plasmid, very difficult for these bacteria to acquire external genes. That's probably why Treponema pallidum still remains susceptible to penicillin and tetracycline so far. But it's important also to know that for azithromycin, it has been described a mutation in 1977 that is now widespread and that is conferring resistance to azithromycin. So it is important to look for potential resistance also in Treponema pallidum for doxycycline. Again, so far, no resistance identified. And in tissue culture, also, our US colleagues tried to select for resistance. It was not possible to identify the emergence of these mutations. And according to these results, in 2022 in San Francisco, the first city to implement DoxyPEP guidelines. And what was interesting is that 2 years later, they were able to show among MSM and transgender women in San Francisco a strong decline by 50% of the cases of chlamydia and syphilis. Not for gonorrhea, and I will go back to that, but this is important to see this decline very quickly after implementation of DoxyPEP in this population. And it was also interesting to see the CDC report in December of 2024, showing for the first time among this population of MSM a decline by 13% of syphilis in MSM. And so this is also quite encouraging. And this might be linked to a large use of DoxyPEP in this population again. What about the other STIs? In the DoxyVac trial, we looked at the impact of DoxyPEP on Mycoplasma genitalium. And what you can see here in blue is people using DoxyPEP, and the incidence is lower. It's not a huge difference, only a 28% relative decline in Mycoplasma genitalium incidence. So maybe not clinically relevant. What's interesting, though, is when you look at AMR, antimicrobial resistance, there was no difference whether or not people use DoxyPEP or no PEP. Although there was a high rate of global resistance, there was no difference between DoxyPEP and no PEP. What about gonorrhea? Well, gonorrhea is clearly the Achilles heel of DoxyPEP because Neisseria gonorrhea is a bacteria that can become quickly resistant to any antibiotic you could use to treat or to prevent this infection. In DoxyVac, like in the DoxyPEP trial in the US, we also saw, despite high level of baseline resistance, a 33% reduction in gonorrhea incidence, which could be interesting. And not only DoxyPEP could prevent asymptomatic STI, because most of these STI diagnosed in those studies were asymptomatic STIs, but also when you look at symptomatic STIs, whether you look at chlamydia or gonorrhea, DoxyPEP was also strongly effective to reduce the incidence of symptomatic chlamydia and gonorrhea infections. Interestingly, a couple of years ago, in 1979, there was a study conducted in Navy men by the team in Seattle, where they look at another tetracycline derivative, minocycline, given to men after sex. It was a placebo-controlled study. And in that study, they also show a 50% reduction of the incidence of gonorrhea in those using minocycline PEP. And they were able to show a clear relationship between the efficacy of PEP and the MIC, the inhibitory concentration of the antibiotics for Neisseria gonorrhea. So in other words, in isolates with high resistance to gonorrhea, the efficacy of PEP was very low. In that study, they also used the same antibiotic for treatment of gonorrhea, which we don't do anymore. And they were able to show a high failure rate, which was not unexpected. And they abandoned the strategy because of the limited effectiveness for public health. In the DoxyVac trial, we also looked at the impact of DoxyPEP on tetracycline resistance in gonorrhea. And you can see in the left-hand side that at baseline, all strains were already resistant. And during the study, when you compare the no-PEP and DoxyPEP, you could see that in red, you have the highly resistant isolates. And you could see an increase by roughly threefold of the rate of high-level resistance gonorrhea with DoxyPEP. And when you look on the right-hand side, you could see that you could look at the MICs, and you could see that the MICs were very high in those isolates. And these isolates, all of them carried the tetam gene, which I showed you on the earlier slide, being associated with high-level resistance. On the other hand, when you look at the other antibiotics, whether it's azithromycin or ciprofloxacin, you don't see any impact on DoxyPEP on the resistance in Neisseria gonorrhea. This is also true for ceftriaxone, a third-generation cephalosporin, which is the first-line treatment for gonorrhea. Here again, all isolates remain susceptible with no change in the MIC, which is important. In addition, our colleagues in the US, Chu and colleagues from the DoxyPEP trial, they looked at the microbiome and they looked at the AMR genes in the microbiome, the gut microbiome. And what you could see is when you compare day 0 and month 6, there was an increase in tetracycline-resistant genes, which was again expected. But what was important is that these authors were not able to show any difference in gut bacterial microbiome diversity or any increase in other antibiotic-resistant genes. So the impact was solely observed in tetracycline-resistant genes. Something I'd like to bring your attention to is cefixime. Cefixime is an oral third-generation cephalosporin. And what you can see on this slide is that at baseline, all strains were susceptible. And during the study follow-up, you could see that there was an increase in the rate of isolates with reduced susceptibility to cefixime, from 10% in the no-PEP arm to 32% in the DoxyPEP arm. And so this is something we need to think about. And when you look at the MIC, you see in the right-hand side that in red, the isolates in people using DoxyPEP had a higher MIC, and all of these isolates also contain the PEN-A34007 allele, which is the allele which is binding to penicillins and in particular ceftriaxone. And we performed a phylogenetic analysis of these isolates, and this is a paper that has been just published in CID. And what you can see in the left-hand side is that you have here all isolates. We had not resistance, but reduced susceptibility to cefixime. And you can see that most of them in black also had the TET gene. Not all of them, but most of them. And all of them also had the TET gene associated with resistance to penicillin. So it is likely that the use of DoxyPEP would select these clones carrying both the TET gene and this allele, the PEN-A allele. And what's interesting is a recent study conducted in the US looking at more than 14,000 gonorrhea sequences from 2018 to 2024, also found an increase in isolates carrying the TET gene, increased from less than 10% to more than 30% in 2024. Explained probably by the shift away from azithromycin to treat chlamydia, and more we are using doxycycline, a regimen for a week, and probably also the role of DoxyPEP since 2022 may explain this increase in TET genes in Neisseria gonorrhea. What's interesting is in this study, they also reported by at least 2 of 4 lineage carrying the TET gene also carried this PEN-A variant, including the PEN-A34 that we also observed in our study. So again, this is something we need to monitor because this PEN-A allele, if you add additional mutation, can be associated with increased resistance or reduced susceptibility to ceftriaxone, which is the main and the first-line treatment for Neisseria gonorrhea. On the other hand, the same authors reported a couple of years ago that when they looked, and that's what you have in the right-hand side, the MIC of Neisseria gonorrhea with either susceptibility to antibiotics or high-level resistance to tetracycline or resistant to tetracycline, and you could see that those who had high-level resistance to tetracycline had somewhat lower CMI to ceftriaxone. So, the jury is still out to know whether or not these isolate with high-level tetracycline resistance will be associated with an increase in ceftriaxone resistance, which is obviously something we don't want to see. Let's now switch to surveillance data in MSM, and these are data from King County and in the US, when they looked at the impact of DoxyPEP guidelines. And what you can see in the right-hand side is the level of Neisseria gonorrhea isolates with high-level tetracycline resistance. And here again, you can see that following probably the implementation of DoxyPEP in King County, there was an increase in the isolates with high-level resistance to tetracycline with this TET gene. At the same time, and this is also probably linked to the use of DoxyPEP, there was a reduced rate of colonization in the nasopharynx by Staph aureus from 36 to 27%, but a small increase in tetracycline resistance in those Staph aureus. Also, they reported an increase in colonization with strep A, group from 4 to 9%, which needs to be monitored. This reduction in nasopharyngeal colonization with Staph aureus is not unexpected, because in the DoxyPEP trial, it was reported by our colleague that in the DoxyPEP arm during follow-up, there was a 14% reduction in Staph aureus colonization with the use of DoxyPEP as compared to those without DoxyPEP. Although this reduction in colonization rate was associated with an increase in a small increase in tetracycline resistance, which is again not unexpected. The same was true regarding MRSA, where you could see a somewhat lower rate of colonization with MRSA in those using DoxyPEP. What about now the efficacy of DoxyPEP in women? We have only limited data in women. The first randomized study was conducted in Kenyan women, young Kenyan women using HIV PrEP. And in that study, conducted over 12 months, a randomized study with DoxyPEP versus standard of care, what you can see on this table is that overall, the incidence of STI remained unchanged. There was a small trend toward a lower rate of chlamydia incidence, but this was not significant in terms of statistics. And for gonorrhea, the incidence was actually higher in those using DoxyPEP. How to explain these results? First, when they looked at tetracycline resistance in chlamydia, they found no resistance, as I mentioned before. No resistance has been ever documented for chlamydia trachomatis so far. They looked also at gonorrhea resistance, and all isolates that were tested were highly resistant, all of them carrying the tetam gene. There was no HIV infection in those women, only one case of incident syphilis, so we couldn't assess the efficacy of this regimen on syphilis. When we asked women about adherence to DoxyPEP, 78% reported high adherence. But when you looked at actual detection of Doxy in hair of these women, only 29% of the visits was DoxyPEP, was doxycycline detected in hair. So clearly, adherence was low in that study, and maybe that explains the lack of efficacy that was seen in this trial. Because when you look at PK, and this is a very nice study conducted by our colleagues from the CDC, where they looked at PK following a single dose of doxycycline in males and women. And you can see that following the use of DoxyPEP, you have very quick peak within 1 or 2 hours. You reach a peak in plasma. And you can see that the concentration remained quite sustained and above the MIC 90 of chlamydia, trachomatis, and Treponema pallidum for a couple of hours. And if you look at the table, you can see that, for example, they remain above 4 times MIC in plasma for chlamydia, trachomatis for more than 44 hours. But if you look at rectal or vaginal secretion, it's also more than 2 days when you can maintain very high concentration. And if you look also in vaginal or cervical tissue, you can see that for chlamydia, you reach very high MIC, very high concentration above MIC. This is also true for Treponema pallidum, not so for gonorrhea, and with the low susceptibility of Neisseria gonorrhea to tetracycline. That also probably explains why this prophylaxis is not so effective for gonorrhea. So what can we do for women? There was another interesting study conducted by General Stewart also in Kenya, this time trying to assess not an on-demand regimen, but a weekly DOT, directly observed therapy with DoxyPEP, 200 milligrams once a week in 60 non-pregnant cisgender women using HIV PrEP. And they follow these women, and then they try to compare the incidence of chlamydia in those women as compared to the incidence they've seen in the prior trial. and they were able to show a somewhat lower incidence, although it's difficult to make cross-study comparison, but still, these data show that when adherence is probably higher with a weekly regimen, you may achieve a lower incidence of chlamydia, although for gonorrhea, they didn't show any difference. And there is an HPTN trial now trying to compare the on-demand DoxyPEP to weekly DoxyPEP among adolescent girl and young women in the US. So let's see what this data could provide in terms of results. Additional data using Doxycycline for STI prophylaxis came from a trial using daily Doxycycline, small studies, but still interesting. The first one was conducted in 2015 among HIV-infected patients with a history of prior syphilis, and showing also a strong reduction of STI. The same was true in a recent study conducted among MSM on PrEP in Canada with a history of prior syphilis, where they were able to show a decline in syphilis, chlamydia, and gonorrhea. And a study in Japan, which is interesting because it's, although a retrospective study, it was conducted among female sex workers, and they were able to show a significant drop in chlamydia, in syphilis, excuse me, and almost significant for chlamydia as well. And this is a recent paper that was published. Let's talk a few seconds about adverse events, because although DoxyPEP is well tolerated, there are still adverse reaction, and in clinical trials, photosensitivity, fixed drug eruption have been documented, although rare. We have to be aware of these rare skin reactions. And what's more common is actually gastrointestinal intolerance. Although these intolerance rarely lead to treatment discontinuation, this could happen: nausea, vomiting, abdominal pain, diarrhea. That's why it is recommended to use DoxyPEP on a full stomach. According to these data, especially those 3 randomized trials in MSM and transgender women, the CDC has issued guidelines in 2024 recommending that MSM and transgender women who have had a bacterial STI in the past 12 months could receive counseling about DoxyPEP to be used as post-exposure prophylaxis. And the way to use DoxyPEP according to these guidelines is for MSM and transgender women living with or without HIV, who had a history of bacterial STI, sex with casual partners without the use of condoms. You need to screen them for chlamydia, gonorrhea, and syphilis before starting to use PEP, to be aware of drug-drug interaction, and you can use a single dose of 200 milligrams of Doxy with food and a full glass of water to avoid esophagitis, which sometimes can happen. You need to take DoxyPEP as soon as possible after sex, no later than 72 hours. And then, obviously, you need to discuss with your patients the benefits and harms of using DoxyPEP, and I mentioned the different intolerance that could be seen. You have to be mindful of drug-drug interaction, also to avoid dairy product, antacid, or kind of supplement that need to be separated by at least 2 hours. And indeed, test for STI every 3 to 6 months, and discuss the ongoing need for DoxyPEP. That's an interesting study that was conducted in Boston to try to assess, according to the different DoxyPEP prescribing scenario, what's the impact on STI that could be averted. And in red, you have the proportion of people that you treat. In green, those STI that you could prevent. And indeed, with an antibiotic in terms of prophylaxis, what you want to achieve is to treat the smallest population possible to prevent the largest number of STIs. And it seems like, in red, when you target your strategy to people having an STI in the past, you kind of reduce the population exposed to doxycycline to reduce the impact of AMR. And you could see that you could prevent nearly 20 to 30% of STI diagnosed in these populations. So this is interesting to keep in mind to decide who should benefit from DoxyPEP. There are other guidelines. In France recently, DoxyPEP is not recommended, but it is still possible to prescribe it in people at high risk with at least 2 STI in the past 12 months. In the UK and Australia, they target DoxyPEP mainly to prevent the risk of syphilis among GBSM and transgender women, although they acknowledge that there might be secondary benefit for other STIs. The European STI guidelines also is more cautious about DoxyPEP, and WHO is still working about issuing guidelines for use of DoxyPEP. So in summary, and I will stop on this slide, I think we have evidence of short-term benefit of DoxyPEP, especially among MSM and transgender women at risk, those who have a history of STI. We have consistent, strong reduction of syphilis and chlamydia incidence with no immediate threat for resistance, although clearly we probably need to still be aware of this potential risk. The impact of gonorrhea is likely to be limited and may wane over time because gonorrhea can, again, become quickly resistant to any antibiotic you would use. Overall, this is a well-tolerated strategy. There are some issues that you need to make your patients aware in terms of gastrointestinal adverse events or skin reaction, but overall, it's a very acceptable strategy, and patients are usually very happy to use it. There are still long-term uncertainties with these strategies, especially in terms of AMR. As long as you're using an antibiotic, you have a risk of selection of resistance. Although the early data we have on the microbiome are quite reassuring at this point, there are some off-target effects that we need to continue to monitor. And when you have a patient using DoxyPEP, if these patients develop a bacterial infection, it's common sense not to use Doxy until you have the antibiotic susceptibility to treat this person. So I think we could probably today implement DoxyPEP among MSM transgender women who have a history of STIs. I think we should limit the use of DoxyPEP to 1 to 2 doses per week. Because 1 dose covers 3 days, so 2 doses would cover the full week. I think it would be reasonable to perform test of cure, especially if doxycycline is used for the treatment of breakthrough STI under DoxyPEP. And of course, we need to continue surveillance for AMR. And I think DoxyPEP is a strategy that would, encourage developing surveillance of AMR in STI. So that would be also a benefit of implementing these strategies. And with that, I would like to thank the different persons who will share their slide with me, Annie Lutkemeyer, Connie Callan, General Stewart, and my colleagues in France who helped me with the study. And I thank you very much for your attention.
Well, thank you so much, Jean-Michel. That was really wonderful. Very clear. We do have several questions that have come in. One question I'll start with asking about any updates on the use of DoxyPEP for pregnant and breastfeeding women. Any problems with that?
Right. So we know, the issue in pregnant women is not really for pregnant women because doxycycline is not associated with, fetal abnormalities. So we can be reassuring in that respect. The only issue is that with doxycycline, it was true for tetracycline. With doxycycline, I would say the data are less compelling, but you had the risk of teeth discoloration in newborns. So I don't know if the data for doxycycline are similar, but there is potentially a risk. So I would think at this point, it would not be recommended, but we can reassure women that at least there are no fetal abnormalities related to the use of doxycycline in pregnant women.
Great.
And you may think that, if you use only on-demand DoxyPEP, the risk of teeth discoloration would be limited. Obviously, if you know the woman is pregnant, you probably would not recommend DoxyPEP.
Right. Right. Great. Okay. And then there was a question along the lines of something I was thinking about as well. There's so much excitement about now injectable PrEP. Has there been any possibilities of injectable formulations of Doxy, for example? Have you heard anybody looking at that? And that might be a way to get around some of the adherence issues, for example, in the Kenya study among the young women.
Right, I think that's a very relevant question. I'm not aware of any long-acting doxycycline formulation being investigated right now, but I'm not sure that would be ideal. It's not like for HIV prevention, because I would be concerned about the impact on antibiotic resistance. And I think that's the good thing about on-demand DoxyPEP is that you should educate the people using it to use it only when it's needed. And if you have continuous exposure to doxycycline, your impact on the microbiome and on all the bacteria would be probably higher. That's why I think daily doxy, I would be a bit reluctant to use it or to recommend it because of the potentially higher impact on antibiotic resistance. So
Yep, fair enough. Let's see, there is a question about breakthrough syphilis infections in people who are receiving Doxy PEP. Is there any impact of intermittent doxycycline exposure on RPR titers, for example?
Well, that's a question that comes up regularly. I would say we try to look at that. We have so few cases of syphilis in those using Doxy PEP. It's really difficult to say. And especially when we, select people who actually have doxy detectable in plasma, we have 0 syphilis.
Okay.
So cases, with the limits of the sample size. So it's difficult to tell. I think we should, keep our attention on this issue. At this point, I think it's difficult to say. But that's a relevant concern.
Sure. Great. Then there's a question about, and you've covered so much, but this is going to ask you about Doxy PEP in any aspect of your talk in Southeast Asia. I mean, certainly there's lots of other, anyway, go ahead. Southeast Asia, Thailand, and so on.
So, so there are more and more now studies, demonstration studies in different parts of the world using Doxy PEP, because the good thing about Doxy PEP is that it's very cheap. So it's not like injectable PrEP. Everyone, anywhere can have access to Doxy PEP. So that's an easy, preventive tool to implement. In Southeast Asia, the rate of, highly resistant gonorrhea is high. So clearly the interest would be mainly to prevent syphilis and chlamydia, and syphilis in Southeast Asia may not be the most concerning STI, not like South America or Africa. So we have studies ongoing in these parts of the world to see what benefit could be provided by Doxy PEP as well. I think interest in Doxy PEP will raise interest in better assessing STIs, better diagnosing STIs, and monitoring AMR. So I think if Doxy PEP will not be used anymore in a couple of years, at least it would foster research on STIs to be able to better diagnose and not do only symptomatic management, and maybe to have better data on AMR in STIs.
No, that's great. And you're anticipating. There was one question commenting that in so many of the low resource settings, syndromic management is what's used, and lots of talk, of course, in publications saying that needs to shift, but perhaps this would be a driver to push people away from syndromic management. Wafa, I see you have a question.
Yeah, thank you very much, Jean-Michel. Fantastic talk. I have a question for you about heterosexual men. Have there been studies looking at population at risk of heterosexual men? I'm just thinking like in many of the countries where ICAP works in sub-Saharan Africa and so on, obviously the rates of STIs is very, very high. And in that general, let's call it the general population. And it would seem to make sense that somehow if we are able to, I know that the studies have been only in women, but I haven't seen studies in heterosexual men. And could that be another population that could be positively impacted by DoxyPEP?
Sure. Well, thank you, Wetha. That's also a very relevant question. I think so far the studies have been conducted in the easy to target population, those using HIV PrEP, and that's also the I would say the easy way to assess STI preventive strategy, to look at people who are monitored for HIV, for example, or for PrEP. So these are population easy to follow in the short, long range. Heterosexual men are difficult to enroll in studies, in any studies. But if you look at the PK data, there is no reason why it shouldn't work. And I would think that, of course, it should work. If it doesn't work, it would be probably because of, again, adherence issue. But, the PK studies, and we've done also the similar study in men. I mean, you find high level of tetracycline or doxycycline in secretion. Doxycycline is eliminated through urine. So, there are many reasons to think that it should work as well in heterosexual men, although we don't have, clinical data to support it.
Of course, we could target similarly people, heterosexual men who had history of repeated STIs. I mean, that's a population, that would be appropriate to target potentially. Thank you.
Sure.
Great. Okay. Let's see. I'm going to ask you a couple of questions on my own side. I was curious why it hasn't been recommended in France, and is that related to particular, I'll say, public health concerns? I mean, I understand guidelines can be complicated and they're not always purely scientific, but anything you might want to comment on there. And I'll add on a second potentially related question, which is, as if surveillance becomes, wider and wider in terms of the way broadly it's conducted, what would you see as sort of the cut point, the no-go line, where you would say, well, there's this much level of resistance, so now we should change the guidelines? Any thoughts on that?
Right. Well, I think, in France, the guidelines were issued in 2024. So, the data were not fully available maybe at that time. And I think, you could see that the guidelines are quite strange. It's not recommended, but still you could use it in people at high risk. So again, it's kind of a paradox, but well, I'm not part of these guidelines. I was not interviewed for these guidelines, so I could say, that's what I could say. This is in French guidelines. If you look at European guidelines, because I'm involved in the EACS guidelines, for example, it's in the EACS guidelines in people using PrEP to, it's allowed or, cautiously to use Doxy PEP. I think the no-go for Doxy PEP would be to demonstrate really an impact in the increase in, ceftriaxone resistance for gonorrhea. I think that would be the red line for gonorrhea, or if we detect some resistance in doxycycline for syphilis or chlamydia, which I hope will not occur, that would be the big concern, because if that happens, then you might expect to see clonal dissemination, like we've seen with azithromycin resistance in Treponema pallidum. So, but at the same time, doxycycline has been used for syphilis for decades. And again, it's like HIV PrEP. you cannot blame Doxy PEP for the use of doxycycline, because we use more doxycycline now than before for the treatment of STIs, because guidelines have changed, and also, azithromycin is no longer recommended as a first-line treatment for chlamydia. And, for chlamydia treatment, we recommend now 1 week of doxycycline instead of a single dose of azithromycin. So, well, that has changed also the overall use of Doxy. But I think these are relevant concerns, and it's the issue with any antibiotic that would be used for prophylaxis. That's why I think we should use as little as needed in terms of prevention. And I think the patients in our cohort are very reasonable about Doxy PEP use. They are mindful about resistance. I think we should have the discussion with the patients and explain, and they are concerned about that, because I would say those using Doxy PEP see the difference. They can notice the difference in terms that they almost see no more STIs, and they're very happy about that. And they want this benefit to be sustained, and therefore they know how to use it and when not to use it. And you don't have to use it for every sexual intercourse. And so I think a wise use of Doxy PEP would be a good way to keep this efficacy for some time.
Okay, so it sounds like there's some nuances in the counseling that are important, and perhaps those who are in the cohort that you follow, I wonder how different they are from a general population, right? They've probably been sensitized and educated over a long period of time. That ties in with a question about how does one communicate with clients to explain, if they take Doxy PEP, that they might be protected from gonorrhea, or they might be at risk of a more resistant form of gonorrhea. And any comments on that kind of counseling?
Right. I think, again, gonorrhea is not the target. It was not intended, Doxy PEP, to be effective on gonorrhea. That was kind of a surprise to see that Doxy PEP, despite the high rate of resistance, even if it's low-level resistance, that it could be effective. So that was kind of a surprise. And clearly, this is not the goal to prevent gonorrhea. The goal is really to prevent syphilis and chlamydia. That's the reason why in our study we try to use the bacterial vaccine to prevent gonorrhea, but it didn't work either. But I think for gonorrhea, antibiotic prophylaxis is probably not the way to go. We should probably try to have other intervention. Vaccine, if possible, would be great. There are a number of ongoing vaccine trials with trying to reduce to see whether this meningococcal vaccine could have an impact on gonorrhea. So we should have some results next year.
Okay, great. Let's see, there's a question that picks up on the study by Stewart et al., the findings among the women. What would you see as the way to move forward with this population of adolescent girls and young women, particularly ways that would have a population level impact?
Well, I think, it is difficult. I'm not sure that these young women are the right target, because I think the first thing for, a prevention intervention is to make sure that people are aware that they are at risk and that they are really willing to be protected against any infectious diseases. So for young women, we have to explain that chlamydia can have, sexual reproductive health issues, or gonorrhea in the same way. I think, for young women, for pregnant young women, probably syphilis would be a concern. And I think there is a lot of work to do before implementing Doxy PEP to make sure that these women understand what an STI means, and to be tested first. I mean, just to have an idea of whether or not they really have a high risk and a high incidence of STIs. So I think I would start by, collecting data in those young women to show them that they are at risk of STIs, they have STIs, these STIs can be associated with potential issues for their future pregnancies, and only in those really aware of this risk and willing to do something about it, I would start to do studies to reduce the incidence. But and again, it's, in the initial study we conducted, and that's why it's easier in people on PrEP, because people on HIV PrEP are tested for STI every 3 to 6 months, and they can see how frequent they are diagnosed with STI, and they receive repeated treatment for STIs. And so at some point, they are tired of receiving, ceftriaxone injections or penicillin injections. And if you can show and can tell them that with an intervention, they will have fewer STIs and fewer treatment for STI, then there is a real benefit for them. Okay. So I think the benefit should be visible for these men or women before they will use the prophylactic regimen.
Right. No, that's a great point. Well, we still have a few questions. We didn't get to all of them. We certainly had a very engaged audience, and I think we gave you some challenging questions to think about. But I think we'll wrap up here. Thank you so much again, Jean-Michel, for your time, for the wonderful presentation, for covering so many different aspects of the topic. As always, with ICAP Grand Rounds webinars, the recording and the slides will be posted at the ICAP website as shown here, probably by the end of today. And I will thank you all and wish you all the best over the holidays and in the new year. Thank you again.
Thank you very much. It was a pleasure.
Great.